Well, hello everyone, and welcome to the first of the Well Project's Leadership Exchange Live, BEEEBAH edition, a live video interview series featuring thought leaders on HIV and breast and chest feeding. BIBA stands for Building Equity, Ethics, and Education on Breastfeeding and HIV, and is a comprehensive multi-tier project that expands upon the Well Project's existing efforts around breast and chest feeding and HIV, and has received funding from ViV Healthcare's Positive Action for Women's initiative. Our first session features me, Ciarra Covin, Program Coordinator at the Well Project, and Dr. Allison Agwu, Professor of Pediatrics and Internal Medicine at John Hopkins. Excuse me. We look forward to the discussion in this series to raise awareness, inspire action, and ensure that women living with HIV can experience their fundamental right to make informed, uncoerced infant feeding decisions. Please, y'all, make sure to leave questions and comments in the chat. Um, I just want to go ahead and make a little note now. I know that it's going to come up again later, but throughout BEEEBAH in our programming, we refer to breastfeeding and breast and chest feeding. While our organization unapologetically focuses on women living with HIV across the gender spectrum, we strive to include trans men, non-binary individuals, and others living with HIV who wish to explore feeding a child from their body. We acknowledge that there are multiple terms to describe this process. And with that, we're going to go ahead and jump right in. I've been looking forward to this conversation because it's not often that you get to sit down and speak to a medical provider outside of the office about breastfeeding while living with HIV. So this is something I've really been looking forward to. Dr. Agwu, would you like to say any more to your introduction?
Um, so I think I definitely wear a lot of hats, and as you said, a professor of peds and adult infectious diseases. But the hats that I wear on a daily basis, I am the director of our program director for our pediatric adolescent HIV/AIDS program, and in that capacity, I lead a team, a multidisciplinary team that takes care of individuals from 0 to 25 or older, including many mama baby pairs, and in that capacity have helped to guide many women through breastfeeding for their infants. And so I think have that perspective and would love to bring that to the conversation.
Yay! So then we'll jump off with number one. We know that you support women living with HIV to make informed decisions when it comes to how they feed their children. Can you tell us how you got there? As we know that it's not currently recommended under the U.S. guidelines.
Yeah. So I think I always say this, and you're supposed to say, "Oh, really?" So I'm not as old as I look. No, just kidding. But no, I've been doing this for a long time, and I certainly have been part of guidance for a long time where we were very dogmatic about the idea of breastfeeding, and for a reason, right? We know for without any antiretroviral treatment or therapy, the risk of transmission is significantly high in the breastfeeding period. So in not just intrapartum, but postpartum with breastfeeding. And so the guidance for a very long time in the US specifically, and even to today, has been no breastfeeding. And I've been part of many conversations with women about that. And we specifically, you write your consult and it says no breastfeeding in all caps. And so definitely was a time that I was there and part of roundtables, et cetera. And I think if the question is how I got to where I am today, I think it is probably how many of us have gotten to where we are is as things evolve and we see the amount of suppression that we can get with as regimens get better and it gets easier to do. And we get to U equals U and you get to the rest of the world, most of the world where breastfeeding is actually the preferred. And even here in the US, if you're not positive, you don't have certain conditions, we're promoting lots of breastfeeding and hearing the stories of women from other spaces and places asking about breastfeeding and saying, well, right? Let's rethink that and let's talk about that. And hearing the stories for women and thinking through it further is how I got here, right? And knowing what breastfeeding meant to me personally as a mom of 2 kids who breastfed probably too long, almost 4+ years for my second one. and saying let's look at it again and think about how we can potentially do it differently. So that's how I evolved.
Wow. So at any time, if you have questions back to me, you know we can do
Sure,
this. We can
sure,
exchange.
sure.
That's a long time to breastfeed. Whoa, congratulations. Um, can you talk about the part of the DHHS guidelines that that does provide information on how providers can support a woman if she chooses to breastfeed, as well as some of the efforts that are underway to update the language used in the CDC guidelines? I know that's such an important thing here, so can you please just talk about that?
Yeah, I sure can. I alluded to the Department of Health and Human Services guidelines, um, which primarily the perinatal guidelines, which talk about how to prevent transmission of HIV from mom to baby. Um, and as I mentioned, the guidance has really always been that breastfeeding not be recommended and not be done as first line. But probably about 2 years ago, based on some of the things that we talked about, data from other parts of the world, U equals U, uh, women asking questions and pushing providers, there became some softening of the guidelines. And I say softening, just more language that started to allude to, yes, we recommend formula feeding as first line in the US. However, if a woman chooses to breastfeed for whatever reason, and not being specific that she had to check A, B, or C, but if there was a choice to breastfeed, and in the guidelines, chest feeding is not mentioned, so that's why I'm not saying breast or chest, breastfeeding, that then it should be more supportive, right, in terms of trying to make sure that you support and provide guidance and what that team should look like. And not a lot of real specifics, but at least a softening of the language that we should not be ripping breasts from babies' mouths and saying there's only one way to do it. Um, that is a little in contrast to some of you alluding to the CDC guidance, which talks about formula feeding only, and that HIV is among conditions like HTLV and Ebola, where breastfeeding should not be allowed, right? So it's a big contrast. And so some looking at and thinking about how do we reconcile those two guidance to get to a point where we still say formula feeding is preferred and recommended, but to allow some of that and to make space for some of that softening to support women who may need be in the space to want to and need to breastfeed. Can I hit you with one?
Oh, yes, I'm ready.
So you didn't say, but I know your experience of breastfeeding, and I wonder if you could talk about your own evolution from where you were to where you are in terms of breastfeeding.
Okay, so I am a new mother of two. My daughter is almost 3 months, and I have a son who is 10, almost 11. And I've been positive with both of those pregnancies. And in the first pregnancy, breastfeeding was not even like in the equation. No one brought it up. I knew that because of my HIV status that I would not be able to. So it was never a question. I went through extreme postpartum depression after birthing my son because, my breasts were getting hard. I couldn't lay down. I just had this baby. He was in the NICU. I'm watching all of the milk just drain out in the shower. And I was just so sad. I felt like that child didn't need me. Anyone could care for him, anyone could feed him, anyone could, take that baby and do what they wanted. Um, so that was really hard. I think that is kind of what deterred me from wanting to have another child. It wasn't until the 2019 U.S. conference on now HIV and AIDS where we sat down. The Well Project did a panel under U equals U's track, and I was on the panel along with a doctor and another, our executive director, and another woman living with HIV who has breastfed. And it wasn't until that conversation that it ever like just made sense to me that breastfeeding could possibly be a thing. It was my placement in the world that was determining whether or not I was able to feed my child from my body. And that was so saddening. It's like if I was born in Africa or some parts of Africa, would I be able to, give my child my breast milk? Is it just because I'm living, on the East Coast of the United States that that is not a thing? So I surprisingly got pregnant at the beginning of this year, and it was not planned. And I kind of was waiting on guidelines to be changed so that I knew that I had another option to feed my child other than formula. And when I got pregnant, I'm like, oh crap, now I have to make a decision. Like, now I have to really start thinking about this. And knowing that I kind of knew where my first doctor, who I had been with for some years, I knew where she stood when it came to HIV and breastfeeding. And she did not surprise me when I got there. So I immediately had to change who I was receiving care from because the criminalization was mentioned but not mentioned. It was threatened a little bit. If you choose to do this, then don't tell anybody. Because if you do tell somebody, then our pediatrician, she is known to call DHS on parents who decide to breastfeed while living with HIV. So that scared the mess out of me. And I finally did get hooked up with a team who supported my decision making. The whole 9 months, I had no clue. I went back and forth because it's kind of scary, And one day I was like, I'm all for it. Next day I was like, what if I'm the one. And then it was like I went back and forth. But just to have a team there who supported whatever decision I wanted to make, it just wasn't a hard stop at no. That is what I appreciated. And I have ultimately decided to breastfeed, and we're about 4 negative HIV tests in, and baby has had nothing but breast milk, and that's where we are now. So excited.
So, thank you for sharing that. And I think, I mentioned earlier when you talked about my own evolution, and it's these stories. I think, I mentioned in our last round table where I remember being part of a discussion where a woman who was a nurse and worked in Africa and had guided many positive women through breastfeeding. And here she was in the States, and she now wanted to breastfeed herself. And, you know, it was her and her husband and the whole team of the OBs, the PEDS ID experts, and the ethicists and the lactation around, and scrutinizing her, who had an undetectable viral load for years, about her decision to breastfeed. And she was like, I want to do what I can for my baby to give them the best leg up, and we can talk about breastfeeding. And I remember us being just so dogmatic, and in the middle of this hour-long hammering of this woman, her husband turned to her and said, yeah, why would you do this? She broke down crying. And I think about that, and I talk about being part of her trauma, and not everyone to do that, and I think about, discussions with moms I had subsequently, where I asked about what did it feel like to not breastfeed and to see the waterworks that happened, and them talk about how they felt exactly like you felt. I didn't feel like I had purpose. I don't bond to that child as much. I don't, right? And, when you look at the data, and you say that, you look at data, and we don't have a lot of US data. We're going to hopefully contribute that with our report on our women who've breastfed, you know, in parts of the world where breastfeeding is done, and there have been trials that have been done. The rates at 6 months, it's less than 1% or less than 2%, or in terms of transmission. And so we're not telling women they can't be pregnant if they're HIV positive, right? We're not taking. So I think we have to. It pushed me to move and keep telling your story, because then one of the questions is going to be, how do you talk to pediatricians, et cetera. And I think first, to talk, you have to listen first.
Oh, that's profound. I like that. I was oh my gosh, it is it cannot be explained, the feeling of birthing a child, and not HIV related. The child was taken away from me, put in the NICU. He was early, so already feeling like I've birthed this child and given him right over, and then you're telling me my body is toxic to my baby, like you know oh my god, my brain couldn't even wrap around it. I was still very young. I was either 23, 22, and newly diagnosed within my first 2 years. So to get all of that messaging at the beginning, now 13 years later, after my diagnosis, is such a hard thing for me to try to convince myself that I'm not toxic. That's where a lot of my anxiety came from. And, even thinking that I had an option where, so long ago I had all of these providers telling me that, no, you can't do it, to now somebody is like kind of shining a light on it. And I'm so trusting, my team of people around me to just support the decisions and the outcomes. And I'm so grateful to have, people like you that are in my realm of support, because I can look to someone and say, no, it has been done
Mhm.
and it can be supported. I'm so grateful. I want to ask, can you speak to the ways that being a pediatrician informs your perspective around HIV and breastfeeding? That seems to be where we run into the some issues, is the pediatricians.
Yeah. So I think I should start by saying I'm both a med peds trained. So I'm an adult and a baby doctor. So I literally take care of the cradle and I try to prevent the grave. I mean the whole spectrum, right? And so as a pediatrician, you're in there, and your goal is to protect babies and kids so they can get to adulthood as healthy and amazing as they can be. And so to prevent smoking around the baby, to prevent anything that can actually create deleterious outcomes. And so you're going in real hard to protect, right? Um, and as a pediatrician, one of the things that you often are recommending is, avoid smoking around your baby, take all your prenatal vitamins, and breastfeeding is one of the things that you definitely recommend, right? And so there is this tension, I think, for as a pediatrician around, well, you got into the pregnancy and the baby is negative. Why would you add this additional potential risk to the baby, right? So I think that it may be, not might be, that is the tension that a pediatrician may feel. And I think it's the and I hear that in the discussions with pediatricians. And so it's important to flush that out and work through that with data and say, well, here's what the data actually says, right? We know that breastfeeding does, higher IQs, less likely to have infections, no, all those things. We can go through all those pieces, better growth, better, all those things that we can list for the benefits of breastfeeding. And then you see on the risk of transmission of HIV, and we're talking about moms, let's be clear, our recommendations around not viremic, right? So not taking any meds, your viral loads, et cetera. We know that risk is higher. And so we want to be clear for everybody who's listening that we are the recommendation, as I and my team have practiced, and where it's recommended is where adherence is there, you have an undetectable viral load, where we're trying to basically minimize any transmission, right? So I think that's really important. And so when you look at the data and say, well, the risk is exceedingly low, I'm not going to say U equals U, because there's questions about, well, where does the virus hide and could you be? So exceedingly low. So you have the benefits of all things with breastfeeding that we know happen, and the risk of transmission is exceedingly low. Then you are actually looking out for the best for that baby, right? When we know HIV exposed babies have more inflammation, they have things that they're not as quote unquote normal. And so why not give them that additional leg up? And I think that's where I come to the discussion, is with listening first. I have to keep saying that. Well, what are your concerns? Because if you can hear those concerns and I can go back, well, here's what that study actually said, and here's what that study actually says. And as we add more observational data, we can then say, well, 100 in the UK, this many here, that many there, and this many million in the developing world or resource limited settings. I think you can start to counter that.
I'm going to jump in and share a little bit of my experience with this child in Missouri, who I'm able to breastfeed this time. And so I had everything prepared before I got to the hospital. My doctor, the OBGYN, infectious disease pediatrician, they all wrote notes and put them in the chart. They let me know that before I got to the hospital, I had a whole plan. So while I'm in the hospital, they have sent like the neonatologist into the room. They have sent the pediatric, like the head pediatric doctor into the room. Everyone trying to kind of sway and let me know what the recommendations were. I've been preparing for this for 9 months, so I kind of knew what I was going to say to them when they got in there. And I just fed them with so many resources, and I was grateful in that experience to have people that listen. Clearly, not just pulling this stuff out of thin air. There's clearly something going on outside of this hospital room that you may not, be abreast on, but I have the support. And after that, I didn't have any more issues once we were able to, get in touch with all of my medical team. But the moment before I left the hospital, we went to do the birth control thing. And, she's having me sign a waiver. And one of the last lines was that it was not 100% effective, but 99% effective. Per the lady's words, very effective. I was like, well, isn't that crazy how this 1% here, it's we can still say very effective, but like the 1% over here is like this really, really big deal. And I always wonder how much that has to do with HIV stigma. Um, because with my birth control, you're trying to tell me that 99% I'm okay. But looking at studies that have been done, even though they are limited, that same 1% just, that is what made you tell me no, a couple months ago. So I just felt like that was very interesting, and they had to agree that I had a point, but I was over it. And I ultimately, ended up being able to make my own informed decision here. And that's what I wanted. And I'm so grateful.
I wonder if I can add to, just to, you mentioned earlier the criminalization piece of this. And I think that really is important. I think certainly I love that 1% here is really, really great. And 1% here is, you're the worst person, we should call CPS, right? And I think that we really, you hit the nail on the head, that the stigma and the criminalization, we've got to move beyond that. I think women who are positive, who are looking to breastfeed, particularly, your circumstance, you've done your research, you know the risk and the limited risk that there is. You are actually not somebody anybody should ever be calling CPS about. And that's, to me, the reason why I want to push the verbiage a bit. I don't ever want any of the guidance or guidelines to be used to say, see, the guidelines say you absolutely shouldn't do this, and therefore we have a reason to refer this mom to CPS because she, in her 5 years of undetectable viral load, is choosing to put her baby at risk, and therefore that we need to take off the table, and that I feel pretty strongly and adamantly about. So thank you for bringing that up.
Oh, you're so welcome. What what would you say to other pediatricians who may be reluctant to support a parent living with HIV who wants to breastfeed?
Yeah. So I talked about sort of first listening to what their concerns were, because I think, again, some of this is based on how we have taught pediatricians for 20, 30 years, right? So change is difficult, right? And so we finally get to the point where most places are trying to test moms in first and third trimester. Yes, maybe check, we're doing that. We're finally getting where we're writing, you can't do this. And now you're telling me to change. So first, making sure we understand what the issues are and the concerns are. And then I think if they're concerned, I don't want somebody contributing to a mom's trauma if they are absolutely against it. And every time she comes in, they're going to give her the side eye and whatever. You know what? Maybe it's not you. Maybe you're not meant to do this. And so let's figure out who is available that you can refer to. And so that that person can actually be supported in her decision to breastfeed and not, again, be traumatized or stigmatized. So I think it's knowing what the resources are that are available, in addition to providing the data and the resources in terms of the Well Project has a wealth wealth of resources that are available. There's the British guidelines, the US guidelines, perinatal guidelines. There's lots of resources to say, well, here are the questions and the answers to those things. But then I think beyond that, it's then if you're not comfortable, you can phone a friend. I'm happy to be that friend. But maybe it's to refer to a person in their team to help guide that mom, that person through that process, because it's such a vulnerable time, I think, because you already mentioned they're your own anxieties that you have, and it is not helpful for you to come in and every time you come in someone's looking at you, oh, let me just take the breast out of the babies, we don't want to be doing that. And so, again, it's supporting them and getting them their education, but while they're doing that, providing them a place where they can refer, et cetera, so that the family can feel supported in their decision.
Oh, that was so funny. I mean, it's not funny for those who have to experience it, having a breast snatched out of your mouth, but that's what it feels like at some point. And I was like, well, if I had chose or did not breastfeed, would I still have been put in that same hospital room? Because all of the messaging in the room was like, breast is best. This is how you latch. This is what a breastfed baby's diaper should look like. I would have been so traumatized had I been forced into not breastfeeding, and had to sit through that because that was excruciating.
So I talk a lot, but one of the things that you led with autonomy, and one of the things we had this whole ethics roundtable when we were first considering how to start the process at Hopkins. And one of the things that one of the neonatologists, great guy, and he's come around in terms of the breastfeeding. And one of the things that he said, well, I guess we could let her breastfeed. And I was like, whew, triggered. It's not about letting, right? It's working with her and her team to support her in breastfeeding, right? Because what we don't want, and we're not speaking to it because it's not your situation here, but the reality is, and what pushed me, and I think the team at Hopkins and in many places, is that for some women, depending what culture they come from, not breastfeeding is literally the mark on the head that there's something wrong with my milk or something, I'm tainted in some way. And in many places that equals HIV. Not that HIV is a taint or anything like that. However, when women have not disclosed, some to their own partners, that not breastfeeding can actually disclose and out them, which can mean potentially being outed from your social situation and support, which can mean violence and trauma to her and her child. So it actually can be a life-threatening thing for her not to. And if we're not in the space to support somebody in that, what we have is then underground feeding, right? I just made up that term, or people secretly breastfeeding because they can't do something else. And when we make ourselves and our approach so dogmatic that people feel like they can't tell us, and they're going to do it anyway. And in fact, they may retract from their care because now there's that desirability and I have to go in and lie every time. So how about I just not? Now you have a risk for mom, not a person not being on their meds, not being suppressed. You actually up the ante in terms of the risk of transmission. So which one is better?
That is exactly what I thought when I was advised, by the provider that, oh, just don't say anything. I'm not that type of patient. I'm not that type of person. I want to give you all of the information so that you can treat me appropriately. Like, I need you to know everything that is going on because otherwise it's just, you're not treating me. So I thought that it would be very unrealistic, and I felt like it would also be very dangerous for me to not say anything. And so I'm so grateful that I was able to find a team that did support that. Um, let's see, I'm just going down our list of questions. What tools or resources do you rely upon when supporting a woman living with HIV's desire to breastfeed? Excuse me.
So I think first it's important it's some of the same resources that I use to support women who are not positive to breastfeed. I think one, we have to stop making that huge dogmatic distinction, right? Breastfeeding is, while we all, we have things to give to give the baby's milk, it doesn't necessarily come naturally. Or sometimes our nipples are inverted. There's all kinds of, there's cracking, there's swollen armpits, there's all kinds of things. So just supporting and resources for just that, right? The process, the lactation consultants, the La Leche leagues, and all the things are, first and foremost. Then, certainly it is the resource, like I said, the Well Project has resources. The BEEEBAH guidelines have resources. There's some nice fact sheets on how to just breastfeed. Then we've created some of our own in terms of what to do if this is going up. If you have mastitis, list of contacts of who to call, the bat phone of where to call, how to call. It's contacts, it's guidance, it's being available. It is, making sure people are seen regularly in support. It's really, it's those pieces. I think the primary piece is making sure people know how to take care of their breasts, support for adherence, because reality is you can be 100% adherent and be doing great, and then this little person screaming 24 hours a day, and all of a sudden you don't remember what time of day it is. So did you take your med? Did you not? There could be that. So tools to help parents continue to be adherent, and supporting them if there are resources they need, because maybe they're not working and there's now changes are happening. So what resources support the family, I think, are all part of supporting somebody in continuing to be undetectable and in their chest and breastfeeding.
So I know that you've worked with parents who have breastfed while living with HIV. Is there anything specific that you would like to share about their experiences?
Yeah. So I think I've worked, and I have to give a big shout out to my nurse practitioner, Marianne Nagrasso, who just jumped right in. She has taken care of, she's been with our program for many years, feels like forever, and takes care of our many mama baby pairs, just, women living with HIV who are younger than age 25 and some older, and their babies. And she just jumped right in and has really guided all of these women through. And so, the experiences have been, one, I want to make sure it's clear that it's not easy, right? So and I'm speaking from the provider perspective, but we do ask regular check-ins. And we probably do a bit more conservative. We do regular blood draws on moms, like, we want monthly viral loads. We want monthly viral loads on the baby. Actually, we don't do monthly viral loads on the baby. We do the regular testing and do, every 6 to 8 weeks or so. But moms, it's get your viral load once a month or so. We want to hear if there's any cracking of the breast. So it's a lot of, we get to know the moms very well. They have our bat phones, they're messaging, they're calling. We have a good connection with the OB team and the GYN team. So it really is, they have an extension, big family around them at all times. Some of it is providing stories. I talked about some of the moms not disclosing. And so providing stories to help them be able to talk about, why they're giving the baby these medicines, and how to cover up those medicines or whatever they need to do. But it really is transparency. Here is the reality of my situation. I'm from whatever part of the world. My mother-in-law is going to come. I've got to hide this or that. And it's understanding and being transparent so we can help support. The experience, I would say, from a provider perspective, has been very rewarding, to hear women, and it's been all women for us, say, this has been such a different experience with my first child, for example. I feel like this child actually sees me and I see them. I feel like my value has been upped. I feel, not depressed. It's been so wonderful to be part of the anti-trauma after saying I've been part of the trauma. It has been anxious at times for us, right? So, mom was late getting her viral load. She hasn't had one in 2 months. Oh no, is there something going on, right? So I don't want to make it seem like, oh, it's smooth sailing. It is literally the team constantly thinking and making sure we're working with these parents. But it's been, I think, doubly rewarding to see these babies growing and doing well, and to see the negative tests come back and say, yeah, we did that. And I say we, the entire team, led by the mom.
Yes, it definitely takes a whole team. And I think that as it becomes more familiar, or, things begin or continue to evolve, I think that maybe practices will be put into place along with procedures. But like in my situation now, I'm feeling like in my head it made sense to get tested
Mhm.
monthly for my viral load. In the pediatrician's head it made sense, but then now it's like, who's sending me to go get these viral loads done? Nobody's. I'm like, hey, like I
Yeah.
know we're caring about the baby now, and that definitely is at the forefront of my mind. But you, I need to continue to be watched as well. At least it made sense in my mind.
Yeah.
But we are doing monthly testing for me, and I was able to advocate that I get that done at the baby's doctor's office to make it a little, less crazy, and monthly testing for the baby as well. So I know that everyone has a different way. You said
Mhm.
that y'all aren't doing it exactly the same way, but clearly it's working. So,
Yeah.
um,
So I have a question for you. So I think in that same vein, so you're absolutely right. We did the same thing, right? So we have a lab where mom can go and get her blood done when the baby is there, right? So why make her go someplace else? And so, but that takes coordination. I happen to take care of some of the moms on the adult side, so I just write the order and having that sort of smooth machinery. I was going to ask you because you asked me, but I think from your perspective, what do you feel is optimally needed to be supported in this? Well, who's on your team? What resources did you need? What do you think is critical for you?
So I can speak to this last pregnancy because I found so many things that worked extremely well. So once I left the first infectious disease doctor that did not support, I was able to, my first line of contact was another infectious disease doctor who she supported it. She referred me to a OBGYN who supported it. He came with a high risk nurse and a social worker. After them, I got set up with the pediatrician, and this was months before the baby was even due. We started talking about a plan. She explained to me some of the treatments that were available, or the treatment that was available, and what we would do, if I continued for a certain amount of time. So that is OBGYN, infectious disease, nurse, social worker. Then I was a high risk pregnancy because my first was early, so outside of HIV. So I was getting like progesterone shots every week. That nurse that came once a week was such a big part of my support. I said, I don't know if they wrote it up this way or that they knew, but just having constant contact with someone weekly was so helpful. My family and friends around me, they like, I feel like if any of them had gone against what I desired, then I maybe would have questioned myself a little bit more. But I had the total support of them around me. So I feel like, as many people that you can get on your side, or at least to, to support you when you might not be feeling the best. I feel like that is the most beneficial thing that we can do for ourselves. And sometimes you have to start early. You can't, like, it would be extremely difficult to get the month 8 or month 9 and then start trying to scrounge together that support. Start as early as possible would be my greatest advice to a parent that wants to breastfeed.
So I'll ask this: have you experienced any stigma for your decision to chest breast past the beginning?
I will say, if anyone is saying anything, it hasn't been said to me. I felt more stigma during the first pregnancy and not breastfeeding. Although I'm American, I have a Jamaican father. And so many of his values. Like, what's wrong with you? Why you gotta get a baby to something? Like, I felt more stigma there. Now it's just, and this makes me want to cry. Like, to sit around in the room and my family's there, and my mom is like encouraging me and rooting me on, and my dad's like, the baby wants something to eat, so he's handing her back to me. Like, that is so fulfilling and rewarding. Um, I think that a lot of the stigma that I experience with anything is the internal stigma. So I'm like, okay, what is today the day? Darn it, I gave her medicine late, or darn it, I took my medicine late. Is this it? I'm constantly having to fill my mind with positive words and affirmations and referring back to other people I've seen in the community who have breastfed while living with HIV and not transmitted the virus. Like, just having to stay. I feel like I'm kind of like retracting back into a shell a little bit because I am really nervous. I am really scared. some days. And it's like, dang, I'm doing this in front of the world because I would like to inspire and help other people. But some days that gets really heavy as well because I don't know the future. But my faith is so strong, and I've seen it happen in so many other areas of my life that I think we can do this. So, day by day, with my support team, we are doing this.
Wow. Thank you for acknowledging that. I think, it's so important to acknowledge that part as well. Because we can, be gung ho. I told you I had my own angst. Like we're doing it, but you're like, okay, right? And you know that you're doing everything and you're even doing more and being conservative. And in fact, I would probably argue that moms are better, parents better at giving the babies their meds than they are at their own, right? Um, and then people ask, well, what about that potential little thing? You're like, I don't think that's a thing, but is it, right? So I think it's important to acknowledge that. But I also balance it with what we do know, right? And the fear of what may happen can prevent us from doing all kinds of things. And I don't want it to be that here. I think the risk is exceedingly low. I feel strongly about that. And I'm glad you have a team that supports you in that. And I think it's important to, again, even acknowledge the angst of that and working through that. And even at the end of the day, because I would be remiss if I didn't say it, at the end of the day, if the point zero whatever percent we think it is happens, it would not mean that you did a bad thing.
Oh, well, thank you. That really wants me to cry now. Thank you, Dr. Agwu. Appreciate it. Because I do often wonder that, and I think it was Portia who made the comment in a previous recording we did. She's a woman that was born with HIV. And she was like, well, if the child were to get HIV, then is what's wrong with me? Like, I was born with HIV. So you're saying that if a baby gets HIV, like, is their life not worth anything? And I'm like, no, that couldn't be the case. And I know that I would so beat myself up if a transmission were to happen. So I thank you for saying that I did not do anything wrong. I'm not doing anything wrong. My baby is so happy. Like, I look at her in the way that she, like, she trusts me so much, and she just is able to make her way down to the breast and latch and all of that. It just makes me feel so good. I feel complete in a sense, and I that's my own personal experience because I know that not everyone has the want desire to breastfeed. But for me, that is something that I felt like I was missing for so long. So being able to do that this time, like, I felt on top of the world. Like, you can't tell me nothing, okay? And we got negative tests. And I know we're just going to continue to put that in the atmosphere. Going to continue to get negative tests. Um, I just can't believe it. I'm still in awe and shock myself.
So one of the quotes I say to my kids all the time is, a goal without a plan is a wish. And so I'm going to say that again. A goal without a plan is a wish. And so if you had a goal to make sure your baby got, the colostrum and all the healthy antibodies and all the benefits, and that was your goal, but you had no plan on how to assure or do the best that you could do that she would be negative, then it's a wish, right? Then you're putting that 15% transmission risk, whatever, if you were taking no meds and just like, we'll see what happens. But that's not what this is, right? So your goal is to have all those benefits be passed to her, and to minimize the risk. And you have a plan to do that, a very elaborate and purposeful plan, right? And so that's why I say that, because I hear the angst and I see it. And I just want to make sure that I say that for you and for others out there, that if you have a plan and it's very well specified and it comes with knowledge and with science and with a team, then if the point oh whatever happens, then it happened, but it's not because of negligence or anything like that. And I think the likelihood that is low to zero.
Oh, that is so warming because you would expect or I would expect for a medical provider to be like, see, we told you, or see, that is my experience. And so many times feeling like the people wearing the white coats feel like they know best for you. So I would feel kind of ashamed to even go back. I feel like I would have to switch my entire medical provider team if something were to happen. I would be that ashamed. But that's a whole nother episode. We're not going to go there. What do you think the future holds for HIV and breastfeeding?
So I think the future is happening. I mean, I think, I can look back even 5 years ago and we didn't have these kinds of conversations. Now the conversations they're happening across the world. So, the UK happening, Canada happening, the US happening, the Swiss are reporting. I mean, so it is evolving. I think the snowball is rolling downhill. And so I think the future, I think we're moving to a space where this is going to be part of guidelines, supporting and not, again, ripping breast from babies' mouths and being in a space of harm reduction, optimization of outcomes. Um, and I think thinking about how to make things easier. Some of what we talked about is how do we reliably assure undetectable. And so I think even as we talk about medications and things, making how do we get to easier? Is it monoclonal antibodies for babies that they can be on, whatever? Is it the injectables for mom? How do we make it easier to support people in the decisions to breastfeed that are, again, not wrong? How do we do that? So I think that's where we're headed. I'm being very intentional in my efforts to do that and advocating for that. Um, so yeah, that's my hope. And these kinds of conversations are so critical because you're not just somebody with HIV who chose it. You're a person, a full person, with a whole history and a whole reason why you wanted to do it and a whole positive intention. I think we've got to get out of that. Just like we had to stop saying, UAIs or unprotected anal intercourse. Like we have to get the people married to the stories to then start to really tell the stories. And we've got to listen. We have got to listen. That's where I hope we're headed. That's where I think we're headed. And I'm being, again, intentional in being part of that discussion and the movement to get it there.
Oh, yes, this is such a wonderful conversation. We are now going to step over and take some questions from the comments. I've been seeing some stuff come in. I'll start with this one. It just came in from Krista. Can you talk also to the benefits to mom and baby about breastfeeding? That's a doctor question.
So I can speak to it. I think, Cece, you spoke to some of this already in terms of the psychological benefits, for mom, lower rates of postpartum depression. I think there are some actual physiologic benefits to babies in terms of decreased risk to moms, I should say, decreased risk of breast cancer. We talk about getting back to your pre-pregnancy weight. I mean, they're literally physiologic effects for mom. For baby, not just the nutritional benefits, in terms of weight and weight gain, et cetera, but also psychological benefits. Babies are happier and healthier. IQ benefits. It's a couple of points. So if you have to go with formula, and I always say this, when a mom has to provide formula, or someone has to provide formula, I say it's only a couple points below. When you're breastfeeding, it's a couple of points higher, right? So the conversation switches a little bit. Lower rates of ear infections or other infections are probably the biggest ones I can think of. I may have missed some. We have some big advocates on there. If Heather was here, she'd add like 4 more. But those are probably the biggest ones I think of from mom and baby side.
So, a person living with HIV, like that doesn't take away any of those benefits. It's just the minute risk of transmission. That's so interesting because I had no clue. I didn't know. Like, I just thought that, people breastfeed fed because they wanted to, or because I don't know. I just was handed formula in a bottle and made sure that I gave the baby that. It's like, whoa, like this decreases mom's chance for some certain types of cancers, and it can help my baby and all of this. Where I thought for me that formula was the best thing ever. So, oh, thank you for speaking to that. This question comes from Heather, and it says, "Can you speak to extended breastfeeding past 12 months in a setting where mom is undetectable and baby is on prophylaxis and doing well?
So that's a good question. Um, for I think I want to say it's a promise trial. So don't quote me if I got the wrong one. And this is again different setting, resource limited settings where there is moms up to 12, 24 months of I think was the duration, and the risk of transmission again. Not with just undetectable moms, so all comers, I think was like 2 point something percent, 2.9%. But again, that's not in undetectable moms. I don't know that I know the answer, and I can look for this past 12 months in undetectable state. I want to say that it's exceedingly low still, but I will come back to you in terms of the actual number. Our recommendation for our babies in our program has been we've been going for 6 months because we know at 6 months it gets a bit harder to try to avoid the mixed feeding that can happen. Now this is all theoretical. Now mixed feeding where you're using breast milk and then mixing in formula or other forms of food can cause more irritation to the lining of the stomach and the bowel, and particularly in parts of the world where there's more diarrheal disease, etc., which can potentially increase the risk of acquisition of HIV or transmission of HIV. Again, that's in resource limiting settings and in areas where, and in the pre-ART era, where moms were not, people were not on antiretroviral treatment. We actually still recommend no mixed feeding, but we haven't had necessarily ART in the US or resource-rich settings to look at that. So we do recommend against mixed feeding. But your question is very specific. And I could say it's low, but I don't know that I have the data to match it. Particularly in our setting. And the data you have is in other settings where people breastfeed for years, 2 to 3 years in some settings. And again, the numbers that I have quoted about 2.9%, so under 3. But again, that's in all mixed, variloads where we're not monitoring as closely. It's a good question, but I think it's again low.
Yeah, I know I had this question the other day. I keep hearing like exclusively breastfeed,
Mhm.
exclusively no mixed feeding. Like, what is that? Do I have to breastfeed this child till they're 5? Like, can I never give this child any other food? What? How does that look?
Yeah, and so for the reasons that I mentioned, again, because a lot of the data comes from pre-ART era and in resource limited settings, exclusive breastfeeding, again, trying to avoid anything else that may disrupt that lining and create transmission. Really, exclusive breastfeeding, you could probably get away 6 months or so. Once you get past that, the likelihood that you're not going to bring something else in gets lower. And so, admittedly, because of that, I get a little less comfortable. So we recommend 6 months, and then you're not a rapid wean, but we tell moms to stock up on that breast milk in the freezer, and then we start to transition that breast milk to the bottle, and then we get the baby off the breast with sort of transitioning to off. 6 months is about where we are because we know that people start slipping the baby food and start doing, so that's when the control is a little bit less, and so that's why we recommend 6 months. Some places, again, in research limited settings, they go much longer than that, with rates that are not astronomical in terms of transmission. So that's what that recommendation for us is based on.
That makes a lot of sense because I was trying to figure out how do you do this. I know, younger in my community, we are introducing things like cereal a little earlier than probably what would be recommended. So that baby needs to go to sleep and stay asleep a little longer. Okay? But I'm not having that. I'm not able to do that this time, and it's fine. I realized that it was something that I definitely felt like I was putting my boxing gloves on a little bit. It was something I really wanted to do, and that I was in it for the long haul. My first cutoff was like 3 months. Now we're coming up on 3 months, and I'm like, I don't want to stop yet. Then, maybe 6 months. One day I called my mom, maybe delusional. I was like, I'm going a year today. That is not where I'm at. We may go for 6 months because this is pretty difficult. And not having the convenience of being able to switch between bottle or formula and breast milk for the days when I'm tired. Like, I realized I probably didn't pump as my supply was starting to go down. So I was like, oh man, I stayed at that pump almost all day yesterday trying to get the supply back up. And just how much of your life is definitely impacted. But if you want it, you can definitely go after it and keep putting the good foot forward and trying. At least that is my motivation from this side because I'm in the thick of it. And I can tell you that it is not the easiest thing at all times. Um, I am looking back over to see, make sure that we covered everything. I think we did. I really like this statement that you make when you refer to being a part of someone else's trauma and you being able to like come back and kind of rectify it now. Thank you so much because then we can, we have this rapport now and you're able to help move our efforts forward towards where we're trying to go. So, thank you.
No, you're welcome. If I can ask you something to maybe close, I know we're getting ready to close. I'm wondering if you can have the last word and maybe talk to some people who may be thinking about how to approach this with their provider. What do you suggest that people say? How should they bring this up? Or what have you learned, good and bad, in terms of how to introduce this for those who are struggling with making that step?
Well, I definitely, in my experience, everyone is not going to agree with you. Some people are going to make it seem like you're making a really bad decision. The choice is ultimately yours. I like what Dr. Agwu said in a previous conversation we had about like us being a team, us working together. Because I got all big in my chest. You work for me, but looking at it as we are all a team, and finding a team that supports. I mean, if you're not able to advocate for yourself in the moment, there are other people, organizations, entities that have people that can advocate on your behalf. I know I was very lucky and fortunate to come across Heather, who she had already been down that road twice, and I wanted to know how I could get how she was, and she helped me. Just another sister out in this world was able to offer and extend her resources to me, and how greatly that has impacted my life. So if you're unable to advocate for yourself, please reach out to organizations such as the Well Project. There are so many resources available here. You can browse through our website. You can read the expert consensus statement. Sign on. You can see so many of the providers who are willing to, say that this is something that they're interested in or something that they support. There is help out there. Like I said earlier in the conversation, make sure you start early. It's going to be very difficult to try to get all the ends tied at the end of a pregnancy. So try your best to do it early. Make sure that you advocate for yourself. I can't say that enough because there's something that I wish that I would have done during my first pregnancy. Not necessarily when it came to breastfeeding because I may not have done it then either. I was too new. But with all things when it comes to our health care, advocate for yourself. If you have a question, ask it. If you need them to explain it to you a little bit more in depth, ask them to do it. Don't just okay your way out of that doctor's appointment because you may be missing some very, very vital information. And you have so much support. There are support groups out here, women who are breastfeeding or who are interested in breastfeeding while living with HIV. We're out here. So just look, reach out. I know I can be a resource. I know Heather is one. The Well Project, I'll always and forever say that. Keep tuning in to these BEEEBAH conversations, part of our Leadership Exchange Live. We'll be continuing to speak to experts on breastfeeding and chest feeding, and hopefully just continue to let this conversation evolve. I'm so grateful to have you here with us today. I'm so grateful for all of you who have showed up. Thank you for your questions, your participation, and all. Look, this is a great comment to end on. This has been phenomenal. Cece and Dr. Agwu's open discussion has fostered further discussions and advocacy for HIV positive women, breast and chest feeding. Yes. Thank you so much. So I am going to go ahead and end here. Thank you all for attending and have a good day.